I am Dr. Greenberg, and today I'm going to be talking about addressing the root cause of psoriasis, the gut microbiome. All right, let's get started and let's do a little overview of psoriasis. So first of all, there are some different types of psoriasis. The most common, of course, is plaque psoriasis. That affects up to 80% of people suffering from psoriasis. There's also inverse psoriasis that affects the intertriginous zones, so the axilla, the armpits, the groin, areas like that. Studies are maybe 25%, but that's usually more than I see in my patients. There's palmoplantar psoriasis, which affects the palms of the hand and the soles of the feet. The numbers are very broad on that, anywhere from 3 to 41%. There's guttate psoriasis, which is like teardrop psoriasis. Some of the research, I think, is too low on it. I've seen statistics like 8%, but I see it a lot in my patients in concert with plaque psoriasis. The guttate psoriasis occurs a lot on the back and the torso, and we'll be looking at some of that. And then there's pustular psoriasis. There's sterile pustules, often affecting like the palms of the hands, and that affects 3%, and that is the most rare. So let's look at where psoriasis occurs on the body. It can be all over. The most common places you're going to see are the extensor surfaces. So that would be the outside of the elbow, where the elbow extends, and then the tops of the knees, where knees extend. But there's really other places as well. Up to 60% of those with psoriasis will get it on their scalp. So scalp psoriasis. The genitals is a really common occurrence. Up to 2/3 of people who suffer from psoriasis at some point are going to get it on their genitals. So I think it's a good question to actively ask your psoriasis patients, do you have it in the genital region? Because sometimes patients are a little embarrassed and they might not bring it up. The belly button is a super common one that people don't think about, but it shows up there. The back, we said, is a lot of times the guttate. The face, it can show up, really anywhere. And then the hands, feet, nails, you'll want to check in there. Nail changes can occur in up to 50% of people, and it can affect the hands or feet of about, maybe 15% of people who suffer from psoriasis. So one thing that's really important to keep in mind is that psoriasis is not just a skin condition. It is a systemic inflammatory disease, and there are numerous comorbidities associated with psoriasis. The most common one I think people know and think of is psoriatic arthritis. So you definitely want to check in with your psoriasis patients on their joints. Cardiovascular disease has gotten a lot of attention in the past few years, and we know now that psoriasis patients are at increased risk of cardiovascular disease. So you're definitely going to want to keep tabs and check in on that with your psoriasis patient. But as you can see, there are so many comorbidities associated with psoriasis. These are all statistically validated, and they really cover, every organ system. So renal disease, cancer, lymphoma, non-alcoholic fatty liver, COPD, sleep apnea, autoimmune diseases, obesity, psychiatric diseases, so increased rates of things like depression and anxiety. And again, the reason why we see all of this in concert with psoriasis is that psoriasis is not just a skin condition, it is a systemic inflammatory disease. So let's talk about the pathology of psoriasis and our understanding of it and how it's evolved throughout the years. So before the 80s, early on, we could see the psoriatic plaques and we thought, oh, this is a disease of keratinocyte dysfunction, right? Keratinocytes are skin cells and they overproliferate at a very fast rate. And so we saw the plaques and thought, skin problem, let's put it in the dermatologist bucket. And we did therapies like methotrexate and UVB radiation and retinoids. But then in the 1980s, we realized, no, there's a lot more to this. This is more of immunologic disease. And we tried therapies like cyclosporin. Cyclosporin is an immunosuppressant we give to organ transplant patients to try to suppress their immune system so that they don't reject their organs after transplant. It's a pretty serious drug. Starting in 1990, we realized that there was this Th1-mediated pathway, T helper cell 1. And so we started using drugs like TNF-alpha blockers. But then starting in 2005, we realized, oh, there's this very huge 17 IL-23 component. Those are cytokines because it's a Th17-mediated disease. So we started getting much more targeted biologic therapies, and that's a lot of where we are today. So you'll see like anti-IL-17 receptor blockers, anti-IL-23, IL-17 blockers. And these are those injectable biologics that we give to patients. So let's take a look at the immune system and look at these T helper cells and why would the body be creating a cascade of Th1 cells or Th17 cells? And to do that, let's go back to how we create a T cell. So when the body first forms a T cell, it is called a naive T cell because it needs information from the body. Where's the problem? What is the problem? What kind of T helper cell do you need me to become in order to go fight that problem? And where it gets the information from are dendritic cells. Dendritic cells are like information passing cells. And we have dendritic cells in all of our organ systems that interface with the outside world. What do I mean by outside world? Well, our skin, of course, right? Our skin's whole job is to interface with outside world. And so that's one big area with dendritic cells. Our respiratory tract, what's the outside world? Well, the air, of course. So I just took a big breath in. That air used to be outside. I brought it inside. So our whole respiratory tract deals with outside world. And of course, our gastrointestinal tract, because every time we eat something or drink something or even swallow our saliva, we are bringing outside world inside the body. So all of these organ systems are going to have dendritic cells and are going to pass information. Now, what are the different pathways and how do they occur? Well, they get activated via different inflammatory cytokines. So if we have IL-12 and interferon gamma, that is going to take that activated T cell and turn it into a Th1 cell. And the Th1 cell is going to produce interferon gamma and TNF alpha. Now, why would we be going down this pathway, creating a Th1 cell? Well, intracellular bacteria, viruses, and protozoa. This is the body's response, is to fight it with a Th1 path. The Th2 pathway, incidentally, is more the allergic pathway. So this is like what we see in eczema, but we don't see that at all in psoriasis. The Th17 pathway gets activated by IL-1 beta, IL-6, IL-23, and TGF-beta via the STAT3 pathway. We're going to create a Th17 cell, and that is going to create IL-17A, F, and IL-22. And the reason why the body would be creating Th17 cells is due to extracellular bacteria and fungi at mucocutaneous sites. What is a mucocutaneous site? Well, sites that produce mucus. So the three sites we just talked about, our skin, our respiratory tract, and our gut. I think we all have gotten a cold and started producing a lot of mucus, so we know that's a mucocutaneous site. And our gut has a thick mucosal layer, so our entire GI tract is a mucocutaneous site. So if we get a bacterial or fungal infection there, we're going to trigger a Th17 pathway. And then there's also Th22 cells. They are involved in any tissue inflammation. So those aren't specific to psoriasis, but we will see Th22 involved in psoriatic tissue inflammation. And then, of course, the Treg cells are the regulatory T cells that help calm inflammation. And so they're underactivated in psoriasis, that they will help engage in immune regulation and tolerance in the body. So basically in psoriasis, we saw we have too much Th1, too much Th17, not enough Treg. All right, let's look at some conventional treatments that are used in psoriasis. So there's a lot of topicals, like a lot of derm conditions. I'll start out with topical steroids, kind of low, mid, and then high potency. There's tar-based therapy, there's phototherapy, so UVB radiation, vitamin D analogs like calcipotriene, and topical retinoids like tazarotene. As we discussed a little bit for systemics, the kind of older treatments are things like methotrexate and cyclosporin. Those really aren't used as much anymore. Now, the kind of first step in psoriasis therapy is the anti-TNF alpha agents. So something like Humira or adalimumab. And adalimumab has been the best-selling drug in the world since 2012. They had over $21 billion in sales in 2022. It's kind of an astounding number. This is not just for psoriasis, it's for autoimmune and inflammatory issues, but it just tells you how much inflammation there is going on in our society, that the number one drug is an anti-TNF alpha drug. And then we move on to these kind of newer drugs that are now turning into the cornerstone therapies for psoriasis. The anti-IL-17 and anti-IL-23 and IL-12 agents. There's a lot of them, and they are more narrow in scope, and they can do a pretty good job of suppressing the psoriasis. But it's just that word, right? They're just suppressing it. It's not treating the root cause at all. There's a lot of side effects with TNF alpha inhibitors. There can be skin rashes, positive ANA titers, antibody development to the drug that we need to stop it. And you can also get this kind of paradoxical reaction where giving someone a TNF alpha inhibitor for another disease, like let's say they have Crohn's disease, can actually induce psoriasis. And I have seen this when I did a preceptorship in medical school at a children's pediatric clinic in a hospital. We would see pediatric patients. There was a 12-year-old girl who had been given adalimumab for her Crohn's disease, and then as a result, she developed psoriasis. Now, remember, this is a drug we use to treat psoriasis, so it's what we call a paradoxical reaction. We really don't know why that happens. We'll talk about something called PASI scores, Psoriasis Area and Severity Index. In clinical trials, if you hear PASI 50, that means that there was at least a 50% improvement in the score from the baseline. PASI 75 means 75% improvement or clearance. PASI 90, you're at 90% clearance, and a PASI 100 is 100% clear. Just as an example, to show you the potency of these drugs and how much they do suppress the immune system, this is a drug called bimekizumab. And you can see at different trial doses of bimekizumab, a PASI 75, a PASI 90, and a PASI 100. These are pretty impressive numbers, being that, for example, the dose of 320 milligrams, 79% achieved a PASI 90, 90% clearance. And at the PASI 100 at a dose of 160 milligrams, 60% of people went clear. Now, usually they have to stay on the drug, otherwise it comes back. And here's adverse events from another drug called secukinumab. So infection happens in 29 to 48%, right? It's an immune suppressant, and nasopharyngitis at 11 to 12%. So there's a lot of side effects from these drugs when we're suppressing the immune system. There's a newer drug for plaque psoriasis, newer in that in December 2021, the FDA approved apremilast or Otezla for moderate to severe plaque psoriasis. Previously, it had only been cleared for psoriatic arthritis. It's a inhibitor of phosphodiesterase 4, and there are side effects like diarrhea, nausea, upper respiratory tract infection, tension, headache, and headache. But the kind of interesting breakthrough for this is that it's a pill, because all the other ones are injectables, and not everyone obviously wants to do an injectable. All right, let's look at psoriasis and how there can be a gut-skin connection and how pathogens in our system can be driving psoriasis. So first, let's talk about the gut microbiome broadly. The average adult human has 3 to 5 pounds of microbes living in their gut. We don't just house them for free, we feed them for free as well. I think that's a pretty astounding number. It's like a hand weight that we, house and feed every day. So why do we have gut microbes? What do we get out of this deal? Well, of course, we can't survive without them. They make things that we need. They crowd out pathogenic microbes. They help maintain a healthy ecosystem in the gut. And we learned that they really are hugely impactful on our immune system and keeping things calm. So let's look at leaky gut. I think the easiest thing with understanding what leaky gut is to start with a healthy gut. So we see a chart of a healthy gut, and it's a cross section of the small intestine. And there's some different sections. So up top, we have the lumen. The lumen is the hole. So, if you swallowed a little plastic ping pong ball, you might just poop it out. And so it's just traveling through the hole from the mouth to the anus. And that's where the lumen is in the body. It's like that hollow tube. That's where food ends up going to be digested and where most of our microbes live. Underneath that, we have that strong mucosal barrier. Of course, we talked about the gut as having, it's a mucocutaneous site. So there's this strong mucosal barrier. We have organisms in our gut, bacteria that help maintain it, like Akkermansia muciniphila, Epicalibacterium prausnitzii. Living under this protected mucus layer is the cells of our intestines, and they have tight junctions to prevent things from getting through as well. And then underneath that, we have the bloodstream. And that makes a lot of sense because the whole point of eating is we need to digest our food, extract nutrients, and get those nutrients into our bloodstream. The bloodstream is the superhighway to every cell in the body, and it's going to take it out to, from the hair on our head to our pinky toenail, everything in between needs those nutrients. And in a healthy gut, we can see that the immune cells, so these would be dendritic cells, are very calm. They're not active because nothing unwanted is getting into the bloodstream. We have a mucosal barrier, and then we have tight junctions, and there's at least 2 layers of barrier. So nutrients can get through into the bloodstream. We want that. But, unwanted bacteria or other organisms cannot get through in a healthy gut. If we look at the leaky gut side, we're seeing a different picture. And one of the main problems we see is this degradation of the mucosal layer. And that's a problem because once the mucosal layer is gone, the cells of our intestines are open and exposed to the contents in the lumen. They can't really survive well like that. So many become inflamed and degraded, and they can't hold their tight junctions. And what we see is an open pathway into the bloodstream of unwanted things. We see LPS, that stands for lipopolysaccharide or endotoxins, and there's many unwanted bacteria that are LPS or endotoxin producers. And we can see once LPS gets in, the dendritic cells get excited and activated. They grab that LPS and they're going to show it to the immune system and say, hey, we have a problem here. And what is the body's response to problems? It's inflammation. And so we see a kickoff of inflammatory cytokines IL-6, TNF-alpha, and IL-1 beta. And if we think back to that immunology slide, these are the cytokines that are going to kick off Th17 cells. And where are we? We are at a mucocutaneous site. So we are going to drive production of Th17 cells, again, the main player in psoriasis, if we have gut microbiome dysfunction, if we have a leaky gut. And indeed, the research supports that psoriatic patients have been shown to have gut hyperpermeability. Hyperpermeability means leaky gut. There's some permeability, right? Again, we want nutrients to get through, but we don't want it to be a leaky gut. And talking about those high serum levels of endotoxins, like LPS, are found in psoriatic patients. And they've found that circulating LPS leads to an increase in cyclic GMP levels within the skin cells, and this dramatically increases the rate of keratinocyte proliferation. Remember, we started by saying we knew that psoriasis was a problem of keratinocyte overproliferation that built up those plaques. We didn't know what was causing it. Well, we know now that LPS in the blood via a leaky gut can drive this process. And DNA of gut microbial origin has been isolated in the patients of blood with active psoriasis as well. We also see fungal problems. So there are higher rates of candida colonization in psoriasis patients. We find it in the saliva, in their feces, and on their skin. And we see generally, when we look at the research of the gut microbiome of psoriasis patients, we do see lower levels of beneficial gut flora. So lower levels of things like lactobacillus, bifidobacteria, Caecalibacterium presbyteriae, and Akkermansia muciniphila. Those last two we talked about in helping maintain the gut mucosal barrier. And we see higher levels of pathogenic bacteria, things like E. coli, Klebsiella pneumonia, H. pylori, Enterococcus faecalis, and an organism called Streptococcus pyogenes, strep. And we're going to be talking about strep and how it is connected. We also see a correlation of GI diseases with psoriasis. It can be IBD, inflammatory bowel disease like ulcerative colitis or Crohn's, but also SIBO and celiac disease. So there is this very interesting strep psoriasis connection. We know that a person getting strep throat can trigger an outbreak of guttate psoriasis. And I've seen this happen in patients. Patients, let's say that I'm treating for something entirely different like acne, and suddenly they get strep throat and they're contacting me. I'm having this rash. I don't know what this is. And it's guttate psoriasis that they've never had before. Strep throats, though, can also make plaque psoriasis worse. And interestingly, we've known that having a tonsillectomy can help improve psoriasis. So if we just chop off the tonsils of people with psoriasis, that seems to help them. This was one randomized controlled study of 15 psoriasis patients who underwent tonsillectomy, and 87%, 13 out of 15 of them saw an improvement of their psoriasis in rates that range from 30 to 90%. And even patients who report that they've never had strep throat, they will have a humoral response, an anti-strep IgA, which shows that they probably did have it. And as it turns out, the strongest environmental factor that's linked to onset and flares in psoriasis that we know of is strep. Interestingly, if we go back to those studies where they removed the tonsils of psoriasis patients, they did biopsies, and what they found was extracellular and intracellular biofilms from group A strep in the tonsillectomy tissue. And so what they think is happening is that the immune system can't penetrate the biofilms, nor can antibiotics. And so there's this kind of low-grade infection of strep in the tonsils, a mucocutaneous site driving Th17, and that by cutting out the tonsil tissue, it's at least alleviated this driver. Now, I'm not recommending, that we chop off the tonsils of our psoriasis patients, but just so that we can really see the effect of Th17 drivers from, let's say, a bacterial cause at a mucocutaneous site. It's very interesting. So for me, for my patients, I really want to get down and treat the root cause of this problem. And so I do gut microbiome testing on all of my patients. So we're going to look at some case studies of how I put this all together. I want to see what is going on in their gut. I need to assess their microbiome for sure and see what could be happening at this mucocutaneous site to drive it. But I also need to assess their digestive function. And I start with their oral health. You want to ask your patients about their oral health. Do they floss their teeth? How often? Do they see the dentist? How often? Are there root canals? This is a mucocutaneous site, and if there's a lot of dental disease, this is going to be driving a process in your psoriasis patients. It's also the start of our gut microbiome. We swallow about 2,000 times a day, so whatever's going on in the mouth, it's going to inflame the system and affect the rest of the GI tract as well. So for me, putting together that gut-skin connection, we know that gut dysbiosis is a driver of systemic inflammation, right? And one way we saw is that leaky gut. And we know that systemic inflammation is a driver of chronic derm disease like psoriasis. We said at the beginning, psoriasis is not only a skin disease, it is a systemic inflammatory disease. And this is how we see that picture coming together. So we have to test and treat the gut. Now, when it comes to these, kind of autoimmune class diseases like psoriasis or things like alopecia areata, there's two buckets for me that I need to address. I definitely need to address the gut dysbiosis, and I do that with the stool and the test, but I'll also need to address the fact that there's probably a toxic exposure somewhere, and that can be anything from heavy metals to environmental toxins in water, or pesticides to mycotoxins, fungal toxins. Mycotoxins are produced by mold, often in water-damaged buildings, and a lot of us live in homes that have been affected and have mold and mycotoxins and don't know it. But these cases are like peel the onion cases is how I like to call them, because sometimes, we need to do multiple testing and kind of really good clinical history. We need to peel back the layers of the onion to figure out what are all these drivers that are driving the Th17 and the Th1 dysfunction. We have to clean them up one by one in order to clear our patients of psoriasis and educate them on what these are so that they can steer clear of them and keep their psoriasis at bay. So if you're on the Rupa Health channel, there's a good chance that you're already doing functional medicine testing. But if you're new to this site and you're not sure what they are, there are so many different types of functional medicine tests. For example, the stool test I mentioned, I like the GI MAP stool test. That's the one I run at every patient. There's oats or organic acid testing. But I also do, as I said, the mycotoxin testing for mycotoxins produced by mold and environmental testing. I also do like Dutch hormone testing. So there's lots of these tests that we can use, and there's different areas of the body that they sample. There's urine, stool, blood, saliva, breath, DNA. We can get a lot of information by using these tests. Most people are familiar with the stool test. I do love the stool tests. They give me a ton of information on bacteria and digestion. I also like the oat because it gives me some more yeast and fungal markers and potential information on like indicators of detoxification. And I use these labs as my roadmap. I know where we're starting. This patient has a lot of psoriasis that I need to clean up. And once I get the lab results back, then I can start to see where is the dysfunction, and then I make the roadmap to clean it up. All right, let's look at the skin microbiome in psoriasis. And we're going to talk about an organism called Malassezia yeast. And if you haven't heard of Malassezia, I do have some other videos on here in which I talk about it. There's a whole sebderm talk, but also I discuss it in eczema, because Malassezia is a commensal organism that lives on all of us. They are lipophilic yeast that eat sebum. So what's a yeast? A yeast is a single-celled organism, and they live on our skin. And the sebum is something that we produce in our skin in every hair follicle. And so it's just going to live, and where the sebum comes out, it's going to eat. Malassezia is present on all warm-blooded animals, and our relationship with this organism is a little complex because it occupies both healthy and diseased skin. So sometimes it's just a commensal and sometimes it's a pathogen. Now, when we look at the skin microbiome or fungal biome, we can see a fungus is among us, and it's really Malassezia that dominates our fungal microbiome. There are areas on our skin that are considered more oily areas, and you'll see that that's kind of the top. So the head, the neck, the face, the chest, the back. These are areas of higher sebum production. And incidentally, these are areas where we'll get acne because acne is fundamentally a disease of sebum production. But these areas are also where Malassezia tends to colonize the most because it's its food source. So you want to live where your food is. And what's really interesting is that we see a connection between Th17 and Malassezia. So a mouse model demonstrated that the IL-23, IL-17 pathway controls fungal colonization and drives Malassezia-induced inflammation in skin. Mice that are deficient in IL-17A or F or IL-23 showed uncontrolled Malassezia growth on their skin. And in Malassezia-exposed skin, we see upregulated cytokines like IL-1 beta, IL-6, and beta-defensin 3, which is an IL-17 target molecule. They're all upregulated in skin that's exposed to the Malassezia. When it comes to Malassezia and psoriasis, it's not that Malassezia is the main cause of psoriasis. It's not. But it can be a factor that exacerbates and prolongs and really makes the psoriasis a lot worse because Malassezia can invade the keratinocytes and then they basically trigger inflammatory cytokine synthesis, and they can also affect the expression of the cutaneous proteins, especially those related to cell migration and proliferation. Again, the fundamental issue in psoriasis. It's really interesting, they've done studies on lesional skin, so skin with psoriatic plaque. And if they apply Malassezia yeast, that will create an exacerbation to existing plaques. But what's really interesting is they took 10 patients with psoriasis and they put suspensions of Malassezia ovalis, which is a species, onto unaffected skin, so areas where they were not having psoriasis. And all 10 of them, that induced the formation of new psoriatic plaques. Really interesting. With scalp psoriasis, we talked about how many patients with psoriasis, their scalp is affected. You should absolutely be thinking of Malassezia. It's going to be a factor. Again, Malassezia really likes to colonize this area. And there are studies that show the treatment of patients with scalp psoriasis with antifungal drugs like ketoconazole resulted in marked improvement of scalp lesions after there was a decrease in the Malassezia yeast cell numbers. Now, I don't use pharmaceuticals. I treat with herbs and supplements, both orally and topically, but I absolutely see that when I address Malassezia on the skin, things get better for my psoriasis patients for sure. All right, so let's look at some naturopathic treatments that we can use. We looked at the pharmaceuticals. But there's something called indigo naturalis, which is a Chinese herb. It's been used in China for centuries as a blue dye, but it's also used as a medicine. If you do PubMed search for like indigo naturalis and psoriasis, you'll get like over 40 results. And there's including clinical trials. Most are from China. I only use indigo naturalis topically. Orally, you can get in some issues with liver injury, pulmonary hypertension, and GI reaction. So I don't use it orally. I only use it topically. But it can be really helpful. And there's many studies that have been done on indigo naturalis, basically showing that it decreases IL-17 and can really improve the Th17 pathway. So there was indirubin in vivo in mice with imiquimod-induced psoriatic dermatitis. So basically they tried to give the mice psoriasis. And the application of indigo naturalis decreased keratinocyte proliferation, decreased IL-17 alpha in lesions, decreased neutrophil infiltration, decreased IL-1, 6, 23, and 22 in lesions, decreased that JAK-STAT pathway, and we can see that it really does help with that Th17 pathway, and it helps topically. For the scalp, something called zinc pyrithione can help with scalp psoriasis. So we've looked at patients who have scalp psoriasis and those who don't. And in normal healthy controls, 46% of the microbial flora is Malassezia. But in those with dandruff, it goes up to 74%. And so there's this huge jump that goes up. And for our dandruff patients, we can see them scratching at their scalps a lot. The histamine level in the scalp stratum corneum with those with dandruff is more than twice those of those people who do not have dandruff. And of course, histamine is going to make them itch. The use of a zinc parathione shampoo led to a reduction in histamine in subjects with dandruff down to a level that was indistinguishable from normal healthy controls. Basically, zinc parathione is something that we use to control malassezia. And again, if you want to learn more about that, check out my seborrheic dermatitis dandruff talk on this channel as well. Another herb that can be very helpful is Scutellaria bicalensis, or Chinese skullcap. Don't confuse this with Scutellaria lateriflora, which is a different type of Scutellaria. This is Scutellaria bicalensis, Chinese skullcap. It's been found to lower Th17 cells, as well as IL-17, IL-6, and IL-23. And Scutellaria bicalensis has been found to increase those Treg cells. Those are the immune tolerant cells that calms down the immune system. The nice thing about Scutellaria bicalensis is we can use it orally and topically. There's capsules, tinctures, or glycerites. It's a wonderful herb. It's used extensively in Chinese medicine. There's several studies. One study found that bicolin is a constituent of Scutellaria bicalensis. So bicolin in vivo in mice with silica-induced lung inflammation and fibrosis, it decreased their Th17 cells, decreased IL-6, IL-17A, and IL-23, and increased Treg cells. Bicolin in vitro was shown to decrease Th17 cells and increase Tregs. Bicolin in vivo in lupus-prone mice decreased Th17 cells and IL-17. And bicolin in vivo in mice with induced allergic asthma decreased IL-6 and IL-17A. So there's a lot of research, again, in China on Scutellaria bicalensis. Berberine is another herb. We use berberine widely in naturopathic medicine and in North America. Berberine can be really helpful. Berberine in vivo in mice with H. pylori-induced chronic gastritis, it was shown to decrease the Th17 cells, decrease cytokines IL-6, IL-1 beta, IL-17 alpha, and TGF-1 beta. And in vitro, it decreased Th17 cells and IL-17. So berberine can be very helpful as well. Bile acids are something you might read about or hear about when it comes to psoriasis. Now, for anyone out there in practice, I think you know there's sometimes research that comes out and it makes these kind of like amazing claims. And then, maybe we all go try and use it and you might not be seeing quite the outrageous effects that the study showed. And I think that's true with bile acids. But I will say I use them. But here's an example. So there was a study in Hungary done on 800 psoriasis patients. Bile acids, we think of them as emulsifying fat, which is definitely true, but they also help break up endotoxins in the gut and they're antimicrobial. So in this Hungarian study, 500 of the psoriatic patients were treated with a synthetic bile acid for 1 to 8 weeks. They claim that 78.8% of those who were treated became asymptomatic and that 25% treated conventionally had clinical recovery. Again, these are, I think, not what you're going to see in practice, but I do give ox bile supplementation for my patients with meals just to give them some of that antimicrobial action to help reduce the impact of LPS or endotoxins. Bioflavonoids are another tool that you can use. So it's been shown that taking orange juice with a meal will prevent circulating endotoxin levels. And bioflavonoids have been shown to inhibit the absorption of endotoxins, especially quercetin. So I do also give bioflavonoids with meals for my psoriasis patients. Again, many of them have a leaky gut, and we know that when you eat, especially if there's fat in the meal, that's when we're going to get the biggest influx of LPS into the bloodstream. So giving something like bioflavonoids or ox bile or eating foods with bioflavonoids, like an orange juice, can help kind of quench the effect that all of those endotoxins will have on your patient when they're eating. All right, let's talk about food and psoriasis. So, when we look at the literature, there was a systematic review that was done on what's going to work in terms of dietary advice for psoriasis patients. It looked at 55 studies. They encompassed over 77,000 participants, and of those, over 4,500 psoriasis participants. And the only diet that consistently showed it helped psoriasis was recommending weight reduction with a hypocaloric diet of 800 to 1400 calories a day in obese and overweight patients. That is not helpful at all to me because, obese and overweight patients, I think we know now, we have a lot more information that there's, metabolic things going on. This is not just someone being lazy and, if they only hunker down, they can lose weight. And recommending a diet of, 800 to 1400 calories a day, that's pretty hard to eat. And so this is not helpful advice. And it's only in patients who are overweight and obese. So what about the thin patients? Well, so, what is the obesity psoriasis connection? Because there is one. We know that obese individuals have increased levels of IL-17 and IL-23. And those IL-17 and IL-23, not only do they drive Th17, but they increase adipocyte synthesis of TNF-alpha and IL-6. So we know that carrying a lot of fat is inflammatory, and that's the connection with obesity and psoriasis. But again, just telling an overweight or an obese patient to lose weight is not particularly helpful. Most of them have tried and can't do it. So there's a study that asked psoriasis patients, over 1,200 of them, what benefited you the most in terms of cutting out certain foods in your diet? 50% of patients reported that cutting out alcohol helped. Well, it's 53.8%. 53.4% reported that cutting out gluten helped. And 52.1% reported cutting out nightshades helped. Well, they're all approximately 50%, right? So it's a little bit of a coin toss. So, what is going on? Well, when we look at gluten and psoriasis, we see that it really makes a big difference for certain patients, and it may make no difference at all for others. So there was a study of 4,534 psoriasis patients, and a gluten-free diet only helped those who were seropositive for gluten sensitivity, being IgG tissue transglutaminase or IgA endomysial antibody. And we know that there's a twofold increased risk of celiac disease in psoriatic patients. So certainly if they're psoriatic or if they have a gluten sensitivity, absolutely cut out the gluten. In 30 psoriasis patients with IgA antibodies to gluten, after 3 months, they're being gluten-free, their mean PASI score improved and it went down, which means that their psoriasis got better. But these all had IgA antibodies to gluten. There were 16 patients with palmoplantar pustulosis, so that more rare one with these sterile pustules, and they didn't test them in terms of gluten sensitivity. 1 out of the 16 had complete clearance, cutting out gluten. 2 had moderate improvement, 8 had mild improvement, and 5 had no improvement. And I think this is a pretty good comp for what you'll see in patients. It's worth trying cutting it out. You can do some testing on antibodies, but it's not going to help everybody. But for some people, they can completely clear. For other people, it's not going to make any difference. We know that gliadin and gluten trigger zonulin release, though, and zonulin increases intestinal permeability. I never recommend that my psoriasis patients eat a lot of gluten because I don't think that it's going to ever be helpful. Okay, what about alcohol and psoriasis? There was a study done, a meta-analysis looking at 23 studies. 18 of them concluded that alcohol consumption was more prevalent in psoriasis patients, but 5 did not conclude that. I would say some of my psoriasis patients do have a history of onset during college when there was a lot of drinking going on. Alcohol, again, is going to be a problem because it increases gut permeability. It breaks down that mucosal barrier and leads to leaky gut. And it's inflammatory. So alcohol is never going to help your psoriasis patients. It's worth checking in on their alcohol consumption and trying to minimize it or eliminate it if they're open to that. But sometimes you'll have patients who aren't drinking any alcohol and, they still have psoriasis. And then there's the big, nightshade connection. So nightshades are plants in the Solanaceae family. Things like tomatoes, eggplants, potatoes, and peppers are the more common ones. Less commonly known, like paprika and goji berries, are nightshades as well. Ashwagandha, the herb, is a nightshade. So it's out there a lot. Nightshades can be really healthy, but they can contain lectins, and we know that lectins can increase intestinal permeability, and circulating lectins can provoke IgG antibody production. Some of them have glycoalkaloids like potatoes, and they can lead to the disruption of epithelial barrier integrity or leaky gut. I think we really need more research on this. There's a lot that we don't know. And again, some patients are going to do better eliminating nightshades. Others, it's not going to make a difference. It's not the whole class often. Sometimes patients realize, oh, it's just when I eat tomatoes. And it may even be raw versus cooked. So when it comes to which foods to eliminate in your psoriasis patients, unfortunately, there are no clear-cut answers. It's going to be a lot of trial and error, and, elimination diets, I think, are not a bad idea to see, what could be potentially inflaming your psoriasis patients and what can help them from cutting it out. But if you're only focusing on the food, it's really often hard to get them to clearance unless it's like, that one-off gluten, real issue with gluten. You're going to have to go to the gut. And on that note, let's look at some case studies. So we're going to look at 2 cases. Our first one is going to be plantar psoriasis, and then we're going to look at a plaque psoriasis. So let's look at Teresa, and Teresa is not her real name, but we'll call her that. She's a 6-year-old female. She had a tonsillectomy at age 16 due to throat problems and high fevers. I think we all know what was going on there. She had recurrent strep throat. And it really is common, especially in older psoriasis patients, to have the history of a tonsillectomy. It wasn't done to improve their psoriasis. It was done due to recurrent strep. She has palmoplantar psoriasis. We see that her feet are really being affected by this. The onset was 5 years ago. She is using a 40% urea and 5% salicylic acid cream every night, plus clobetasol. Clobetasol is a class 1 super potent steroid. Clobetasol is 600 times the potency of hydrocortisone. So she puts on the clobetasol and the urea and salicylic acid cream every night. She wraps her feet in plastic wrap and socks, and she has to sleep like this. And this is as good as it gets. It's hard to walk and wear shoes, but if she doesn't do this wrap every night with like clobetasol, her feet are cracked and bleeding and she can't walk at all. She has already eliminated gluten, nightshades, sugar, dairy, and alcohol. She's still like this. So let's run the GI map stool test and an oat. Okay. First thing we see is that she actually has a pathogen, enterohemorrhagic E. coli. Now, she's not having bloody diarrhea, so she picked it up somewhere in the past, but this is a big LPS or endotoxin producer. This is really inflaming the system. She also has high levels of H. pylori, and that is really going to cause an issue with her gut. H. pylori lives in the stomach, and it can induce a hypochlorhydria. If you want to hear a little bit more about that, go watch the acne video on this channel. I really talk a lot about H. pylori on that and kind of what it does to the gut. And then we can see her commensal bacteria. We're looking at 2 phyla here, Bacteroidetes and Firmicutes. This gives us a snapshot of about 85% of the good gut bacteria. And we can see that she's low in both. So this is what I call insufficiency dysbiosis. She has insufficient amounts of beneficial gut bacteria, and this is an inflamed gut. When we look at dysbiotic bacteria, we see Staph aureus is high, and we see Streptococcus spp. And I just want to point out that the spp means all the species of Streptococcus, so this is not necessarily Strep pyogenes, we don't know. But her Citrobacter is very, very high. The E9 means times 10 to the 9th power. So I don't know if this is a billion or 100 million. This is a tremendously high amount of Citrobacter. We can see it's in the class of inflammatory and autoimmune-related bacteria. It's because it's so inflammatory. A huge LPS or endotoxin producer. This is not helping that psoriasis on her feet at all. She's got some candida that showed up on the stool test. Her elastase is low. We see this with that hypochlorhydria in H. pylori. So the low stomach acid can affect the signal to the pancreas, and it's not producing enough digestive enzymes. And her anti-gliadin IgA is high, despite the fact she's eliminating gluten. This is where we're going to check in and make sure. A lot of times patients think they're avoiding gluten, but it's getting in. So this is where we have a conversation about really all the places it can be hiding. Like some people don't realize gluten is in soy sauce. It is. Soy sauce is fermentation of soy and wheat. If you switch to tamari, that's a simple change. It tastes the same. Tamari is just soybeans. But gluten, really those patients that want to avoid gluten, they need to read labels. Gluten is insidious and they throw it into random things. I have had patients get inadvertent gluten exposure with like beef jerky and ice cream, the things you just wouldn't imagine that will contain gluten, but unless you're reading the label, they do. Her oat organic acid test shows that there's a high fungal overgrowth. So arabinose is the marker for candida. but there's some high aspergillus markers, and then also some Clostridia bacterial overgrowth. There's good and bad Clostridia in this genus, but this tests for the more bad guy Clostridia. So a lot of fungal overgrowth. And also, if you're not familiar with the OAT, the asterisk means it's an inverse marker. So when pyroglutamic acid gets high, it means that you're low in glutathione, and she is low in glutathione. So we did what called the mycotoxin test. There was enough in here that with aspergillus and, some stress to glutathione, I felt she might have mycotoxins. She did have a lot of mycotoxins, aflatoxin, huge amount of gliotoxin, and citrinin as well. So this was just a huge amount of mycotoxins. Again, that toxic piece that I know is there. I just need to find it. So kind of wrapping up her overgrowth and the issues that we need to address for her, she's got H. pylori overgrowth, dysbiotic overgrowth of staph, strep, citrobacter, and Clostridia. She's got an inflamed gut, low commensal bacteria, high anti-gliadin IgA, fungal overgrowth, candida, and aspergillus. Her glutathione needs support. She has high levels of mycotoxins, aflatoxin, gliotoxin, and citrinin. So what am I going to do to help her? Well, the first thing to note is that protocols are individualized. So this is not what I will do for every psoriasis patient. This is what I do for Teresa based on her gut microbiome testing. This is where going in and doing that functional medicine testing on each patient is really helpful. So you can see all the problems that are particular to that patient. And a note that plans change every 2 to 3 months. So all the things I'm going to review that you see here, I did not do them all at once. I did them in multiple plans, but we'll look at the progression of her photos in a minute on different plans. So first, to address the bacterial overgrowth, I'm going to use beautiful antibacterial herbs like Scutellaria bicalensis and berberine. I do add the ox bile and bioflavonoids to meals. For fungal overgrowth, we've got our beautiful antifungal herbs, things like neem, grapefruit seed extract. H. pylori, again, I don't do pharmaceuticals, so I do things like DGL and mastic gum and, more naturopathic H. pylori plants. And for the oral microbiome, even though she's had her tonsils removed, on all my psoriasis patients, I do herbal nasal spray and throat spray. They're antimicrobial because it's not just tonsils. We have what's called Waldeyer's ring of lymphoid tissue in the back of our throat, and tonsils are part of that. But even when you remove the tonsils, we have other lymphoid tissue back there. And, I think it's very possible that, especially in these psoriasis patients, they could be colonized, whether it's strep or other things. I think it's worth doing some oral and nasal microbiome treatment. So all of them get like an herbal colloidal silver or propolis nasal spray and throat spray. For her low commensal bacteria, I'm going to give probiotics. I like the spore-based ones. Prebiotics. So, you can give prebiotics like a polyphenol, like a pomegranate cranberry blend, but fiber really is a prebiotic. So work with all my adult patients on getting at least 35 grams of fiber per day. We also work on 30 different plants a week. We need quantity and diversity to build and maintain a healthy gut microbiome. Again, we really went through making sure she's really, truly eliminating gluten. I gave her some liposomal glutathione, and I do treat the mycotoxins with binders as well. So there's lots of good binder blends out there, maybe with zeolite and a little bit of activated charcoal and things that are going to help bind up those mycotoxins. I do use topicals as well. So we use some Indigo Naturalis balm and some zinc purethyon shampoo. You can use the shampoo on the skin. And so I was having her wash her feet with it. We did have a talk about mycotoxins and testing for mold and all of that. This patient decided she didn't want to do that, which I do think was a mistake, but that's, an individual's right. So let's take a look at her progress. So we can see that at the first visit, there's a lot of problems. And this is using clobetasol and the urea and salicylic acid. I cannot emphasize how strong clobetasol is. Just within 2 months of doing the oral and topical plan, we see where she's at now and that she's not using clobetasol anymore. I would have considered a win just to stop clobetasol and not get dramatically worse, but we can actually see things are dramatically better. And then 2 months after that, we're seeing, basically clean and healthy feet. And she wasn't having to wrap her feet in plastic and all of that every night. The other foot, again, a lot of cracking and damage. at the first follow-up, so the second visit, and then 2 months after that, we're seeing much better feet. This was the side of her foot. There wasn't a picture at the first photo, but at the second one, we can still see a lot of inflammation. And then by the third visit, just healthy feet. She could wear sandals again, and she was just thrilled. Same with this foot. I'm sad I don't have photos of the first visit for these, but, it was pretty bad. And she's got, normal feet now. So she was very thrilled with, how things progressed for her. So for our second case, we're going to look at a case of plaque psoriasis. So this is Tom. Again, we're calling him Tom, not his real name. He's a 39-year-old male with psoriasis, and his onset was 20 years ago in college. He was on one of the biologics, ustekinumab. It did get him 95% clear. So this is a biologic immunosuppressive. We talked about it's an IL-12 and IL-23 inhibitor. But he didn't want to be on it anymore, so he discontinued, and the psoriasis came roaring back. It was getting worse and spreading to every part of his body. So I'm going to run that GI map stool test and an OAT on him. When we look at his stool test results, we see that there's some moderate H. pylori. I treat H. pylori at any level. And for his microbiome, we can see that one of his phyla, Bacteroidetes, is low. So it's kind of half of that insufficiency dysbiosis picture. Of the two phyla, Firmicutes seems to be more inflammatory and Bacteroidetes more anti-inflammatory. So we definitely want to get this up. In terms of his opportunistic bacteria, he had a high level of Morganella, which is a high histamine producer, and some Proteus, which is, even though it's a low level, Proteus is pretty inflammatory. He showed up with a little yeast, Rhodotorula, and he has protozoa. So he has Endolimex manna parasites. And I treat all protozoa as well. Remember, it triggers that Th1 pathway. And his secretory IgA is very low. And for me, this is indicative of a leaky gut. On his OAT test, we see that his candida is high. So he's got, some fungal overgrowth in addition to the Rhodotorula. His bacterial markers are high, and oxalic and glyceric can indicate fungal overgrowth. His glutathione is low. Remember, this is an inverse marker. And so, there's a lot to treat here. So for Tom's issues, he's got, some H. pylori overgrowth, some Morganella and other overgrowth. He's got some of that low commensal bacteria, like the whole phyla of Bacteroidetes, a low secretory IgA indicating leaky gut, Candida and Rhodotorula overgrowth, Endolimex nana, and low glutathione. So we did run a mycotoxin test on him. His came back normal. There can be two reasons for this. Either he doesn't have mycotoxins, and maybe there's some other issue, or sometimes people are, so overloaded with problems that they're not detoxifying it and it's not in their urine. Okay, to treat Tom, so just a reminder that protocols are individualized and his plan changed every 2 to 3 months. We did antibacterial herbs for him on his bacterial overgrowth, along with oxbile and biboflavonoids. Antifungal herbs for him. There's things like Uva ursi and Pau d'Arco, in addition to the ones I mentioned previously. H. pylori protocol, antiprotozoal herbs, artemisian, walnut hull extract. There's a lot of good antiprotozoal herbs, and they're very effective at cleaning them up. You don't need pharmaceuticals. For his low commensal bacteria, again, probiotics, prebiotics, 35 grams of fiber a day, 30 plants a week. For his low secretory IgA, there are formulas with immunoglobulins, so it's an IgG, IgA, IgM formula. I gave him some liposomal glutathione, and again, for him, indigo naturalis balm and zinc pyrithione shampoo. So let's see how his treatment progressed. So at the first visit, we're seeing some pretty dramatic psoriasis. Just in 2 months, just a huge improvement and decrease in inflammation, and 4.5 months, again, a huge improvement. This is just the other leg. And again, you can see in the first follow-up visit at the 2-month mark, it is still there. We can see at the ankle, but just a whole different level. And then, healing up at the next visit. This is the arm, the 2-month mark, and 2.5 months later. And we can see hair even growing back. And then the back. And this is more of a guttate presentation. At the 2-month mark, there's still a pretty good amount of psoriasis, but at that next visit, things are much much calmer again. So what are things to consider if you want to treat this way? Well, when treating skin, think of the gut. You'll want to run these functional medicine labs and see what's going on in there. Analyze all the problems that you'll need to address on both gut labs and any other testing that you do. Decide what order you want to treat them in. Don't try to treat everything that's wrong all at once. That is just too much to throw at one person or one protocol. You'll need to learn the best protocols to treat each issue, both internal and topical. You want to adjust based on your patient. Is this an infant, a toddler, breastfeeding mom? What allergies do they have? I like to move through different protocols every 2 to 3 months, and you'll want to treat beyond skin clearance. So just as soon as the skin clears, it's not really the time to pull back. You'll need to keep treating. Does it work for other dermatologic conditions? It absolutely does. I treat all of my patients this way, whether it's psoriasis or eczema or acne or alopecia areata or rosacea. I've got lots of videos on this Rupa Health channel, so you can go watch some of the other videos and see how I'm addressing things. But if you really are interested in this and excited by how to treat derm this way, please take a look at my root cause dermatology courses for healthcare professionals. You can go to rootcausedermatology.com. And I've got live sessions. So they're 4-month intensive cohorts for licensed healthcare professionals. And then I have self-paced courses for those who are able to order labs and they're healthcare professionals, but you're not licensed. For the 4-month cohorts, they're really fabulous intensives. It's a combination of recorded content as well as live sessions where we get together every other week with our group. There's lots of clinical pearls. I talk about how to treat derm via telemedicine, lots of case studies, and practice with the labs and cases. There are 7 of the most common derm conditions that we'll treat, and derm is the number 1 reason why people go to a doctor, so there's lots of people looking for this. We do acne, eczema, seborrheic dermatitis, psoriasis, rosacea, hair loss, and keratosis pilaris. There are 5 detailed case studies for each disease. So instead of seeing kind of a generalized list of things I did like here, you will see the exact treatment plans, both oral and topical, that I give for each patient for all 35 cases. There's advanced functional medicine lab training. I will teach you how to interpret the GI map stool test, an ode, a mycotoxin, the Dutch test, learn how to treat gut dysbiosis like H. pylori and SIBO, and much, much more. It's a really great area of specialty if you're looking for one. Again, there are so many people looking for this and so few functional medicine practitioners who are really focused in this area or doing it well. So you can see you have to get beyond just, food. That's only going to get you so far. So please go to rootcausedermatology.com. You can go to the courses for medical professionals. If you enter your information, you'll get access to download the PDF, and all the information will be in there. There's also a Calendly link where you can set up a 10-minute call with me, and I'd be happy to chat with you and answer any of your questions about this. And don't forget that you can order all of these functional medicine labs and more at Rupa. It's one place, and they're going to handle sending these kits to your patients and helping your patients get them done so that they're right. So thank you so much for joining me for this talk on psoriasis, and I hope you'll join me at some of my other videos. Thanks.
Welcome to Rupa Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Rupa Health Magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rupahealth.com.